them into the Q&A panel on the right side of the screen and submit your questions to all panelists. And we will have time at the end of the webinar to respond to questions. That's all the housekeeping notes that I have. Welcome to Integrating Disability into Medical School Curriculum, Practical Strategies, and Resources. My name again is Susan Haverkamp, and I'd like to just take a moment to thank our sponsors. The AAMC Group on Diversity and Inclusion sponsored today's webinar. I'd like to say a word about the GDI and how disability is included in their mission. We will have the chair and chair-elect of GDI. They've agreed to share their thoughts at the end of this webinar. One AAMC priority has been to increase diversity and inclusion in academic medicine and to advance healthcare equity in the United States. The Group on Diversity and Inclusion works with AAMC to assist medical schools, teaching hospitals, academic and professional societies to advance diversity across the entire professional spectrum. In addition, GDI strives for the ultimate goals of providing care to the underserved and reducing health disparities. AAMC's commitment to diversity includes embracing a broad definition of diversity that spans aspects of human differences, including socioeconomic status, race, ethnicity, language, nationality, sex, gender identity, sexual orientation, religion, geography, age, and disability. So I am the disability issue representative to the GDI. My role is to raise awareness about disability and health issues in AAMC. We know that medical advances and population aging all but guarantee that every clinician will see patients with disabilities. So today we'll discuss specific tools and strategies to help you incorporate disability into existing courses and clinical experiences for medical students. Our vision is to have disability included in medical education so that future physicians will be prepared to care for a diverse patient population. So that is what I wanted to say. At this point, I will turn the microphone over to Dr. Peggy Turk.
Well, thank you, Susan. If you could pass me the ball, that would be good too. I am, as you will hopefully see on the next slide, thank you, a member of the Department of Physical Medicine and Rehabilitation, and you can see my disclosures there. And I have been elected the person to actually talk the most about this, but you'll also hear from Barbara DeVore, who is the Director of Development at the Independent Living Center of the Hudson Valley. We have worked together for quite some time along with Dr. Susan Haverkamp and trying to put together what we hope is a very interesting topic for you. It certainly is an interesting topic for us. Our goal, as you heard from Dr. Haverkamp, is to help people move ahead in looking at disability education being integrated into the medical school curriculum, not as something separate, not something to add, but rather to integrate in the already existing and very full medical curriculum that with which we all deal. So you can see in the outline here, we'll start by discussing some population effects about disability, and then focus on the importance of ensuring that clinicians are knowledgeable about disability, reviewing some areas in the curriculum that might be ripe for integration, and then some specific tools. And I promise we will have problems at the end for questions. So our belief is, as I mentioned, that disability education is more than disability awareness, but awareness is a good place to start. And so we will start with issues of epidemiology. This screen shows that disability is increasing in the U.S. It also is increasing globally. I suspect this is not anything new to anybody who is on the call or on the webinar. WebinX, excuse me. And this is, of course, related to aging, to new technology, so people are surviving longer, people are actually surviving, and we have some newer techniques that help with earlier recognition, and this is particularly clear in children with disability, and in particular cognitive and mental health impairments, because that's really where we're seeing the increase in the childhood onset disability area. But what this screen shows is the increase in the number of adults with disability in the U.S., and we have about 50 million people that experience disability in the U.S. right now. This is a graph that was actually developed by Michael Yeager, one of the disability and health research team, and it's taken information from an article from Dr. Lisa Iazzoni, you can see the reference below, who is a very well-known disability researcher. And she's used the National Health Interview Survey data from 1998 to 2011, and you can see that there's continued increase in disability in just that 13 years. The bottom line is the yellow line talks about complex activity limitations such as self-care, homemaking, social or work limitations. The blue line, the next one up from the bottom, are basic limitations such as problems with movement or mobility, problems with hearing and vision, mental health issues, or cognitive issues. And it's the red line that is the combination of those two. And again, you can see that there just continues to be a rise. This is, as a caution, this is meant to show disability. This is not meant to show decreasing health. People with disability actually can be healthy, and that's important to remember. But people with disability may require some different ways of getting histories, of recognizing disability in a variety of areas. So again, this is not health, this is actually disability. And this helps us recognize that disability is more than ICD codes or chronic conditions or any way that we typically think about disability. Disability is also more than physical impairment. We need to look at disability as a broader definition. And in fact, disability is actually the mismatch between a person's capacity to perform a related, an activity that is related to the impairment or condition, and the ability of the environment to be modified, which will enhance the function. So, for instance, someone who uses a wheelchair may not claim a disability because they're independent in getting in and out of the chair, they're independent in self-care, they get to work, they can get into the car, they drive themselves to work, they do a full day of work, they come home, prepare the meal, they've gone shopping beforehand. These people may not even believe that they have a disability. We probably would include them in the area of disability, but this also gives you the broadness of what disability is. It's not just a diagnosis. It's not just a physical impairment. It can be a functional limitation, a cognitive impairment, limited social participation, mental health impairments, and sensory impairments, which is what the previous slide just showed us. And disabilities are everywhere. You can just look at your own family or within your own community. And to further look at issues of disability, disability can actually result from chronic conditions. Many clinicians don't really think about their patients with chronic conditions as having disability, and yet a person with diabetes may have a vision impairment or may have a motor impairment because of neuropathy. Or a person with obesity may have some functional limitations related to their ability to not get around as much or have more problems with shortness of breath. And people with COPD or cardiovascular problems may also have movement impairments. So although chronic health issues are not disabilities, they may lead to disability. So we actually have a very, very large group of people who do have disability at some level, which is why we believe it is important to consider this kind of education for our medical students. And why does this all matter? I think it's important that we begin the discussion hearing from someone who can really give us some of the important issues related to this. And at this point, I'd like to bring Barbara DeVore into the discussion. She's a longtime colleague of mine. She's taught me a lot about disability in general, has given some positives and negatives of healthcare encounters. Secondarily, I will tell you that Barbara actually is a woman with a disability. But that's pretty secondary in how I've learned much from her. So Barbara, if you can take it from here, please.
Thank you, Dr. Turk. So I'm going to talk just a few minutes about disability, and I am speaking from the perspective of the disability community. So both through my personal experiences, which have been many, as well as my decades of work with people with disability. I work in a community-based organization that is run by people with disability and helps serve people with disability and create a more independent world. So disability is part of people's identity, but it's one piece of the puzzle. It's a really important piece. People with disability come to the medical encounter with their history. So for some people, such as myself, there's a long history of disability. Some people may come to a physician's office when their disability experience is more recent. They were, say, recently had a chronic condition that caused disability, or they had some kind of a trauma. But people with disability have experienced stigma, discrimination. They're oftentimes isolated. In our society, people see disability as something very negative, sort of outside of the normal. And all of these factors negatively influence the partnership that a physician tries to develop with a patient. So I think it's really important that physicians understand that up front, that there could be a lot of experiences that make someone walk into a physician's office with something less than a positive attitude. However, equally important, the same patients come with all the other aspects of their lives that many of the patients without disability come with. Their gender, their marital status, their race, their ethnicity. So I see disability as one piece of a very large puzzle that needs to be considered in the physician-patient interaction. We also have found, I have personally and in my work with other people with disability, is that physicians may over-medicalize problems. Let me give you an example. If you have a patient who comes into the office and they are overweight and very sedentary, you may discuss with them exercise. You may talk about the importance of moving more, eating less. You help them figure out how they can get exercise. For example, maybe they're going to walk the dog before they go to work. However, if you have a disability, oftentimes physicians will prescribe physical therapy, when in fact the interventions that you are describing for your patient without a disability may be totally appropriate for the person with a disability. Permanent long-term behavior change, which is what you're trying to do, really isn't fixed by 6 weeks of physical therapy. You want people to change their lifestyle, the behaviors that put them at risk for added diseases. And the answers may very well be the same. I know personally, I sort of started down on that overweight inactivity road that many of us do when we start to hit middle age. And I had a very smart physician that said to me, join a gym. And that has been a part of my life for a very long time now. And while I would like to say my weight is always stable, but maybe not quite as stable as I'd like it to be, I'm really extremely healthy as a wheelchair user. And I attribute the moving more and eating less to part of that health. The last point, and it sort of seems kind of obvious to people, but it can't be stressed enough, that people with disability are people, and we are complex. I imagine, as all the patients that you have, that the physicians have that do not have a disability. Because as Dr. Turk said, we're living longer. There's a lot more people with disability in the world, and they're growing old. And they are growing old with diseases that are similar to the diseases that are affecting people without disability. We're getting heart disease because we eat too much fat and we don't exercise. We are under stress, stress related to work, to children, to finances, things that affect our physical and mental health as people without disability. Smoking is a very big issue in the disability community. We are working at trying to better understand the high smoking rate for people with disability, and we conducted focus groups with people with disability who smoke. I had a gentleman in the focus group. He was a New York City cop who got shot, and he became a wheelchair user, but he was suffering from lung cancer. Not because he was shot and using a wheelchair, but because he's a 3-pack-a-day smoker. So these kinds of issues are the same kind of issues that physicians deal with people without disability. You know, on the positive side, we also need preventive care. We need our colonoscopies, we need our flu shots, we need family planning services as people without disability. So the idea that you think of people as people means that you have to think of creative ways of solving some of the challenges that result from the disability. What we always say in our community is it isn't always about the disability. And it's really important for physicians to be trained to see the person as a whole person and have the same expectations that you have for people with disability as you do with people without, that they are going to live a healthy and productive life. Thank you, Dr. Turk.
Well, thanks, Barbara. And to reinforce what Barbara said, disability is only one aspect of the person, but it is often the only one that clinicians see and actually see first when it is that obvious. So this screen shows the results from the World Report on Disability that was supported by the World Health Organization and the World Bank. And it was published in 2011, and as a disclosure, I did contribute to this report. There's data that is from developed and developing countries. The information from the developed countries mostly came from the U.S. The most rigorous data mostly came from the U.S. and from Great Britain. But the information I think here is rather impressive. And yes, there are over 1 billion people in the world who experience disability. But I think more importantly, people with disability are twice as likely than people without disability to find that their healthcare providers or their facilities are somewhat lacking. They're 3 times more likely to be denied health care, which continues here in the U.S. And they're 4 times more likely to be treated badly in the healthcare system. And I think it's this last message that really hits home to those of us who work with people with disability. Barbara, I think, was very kind in her message to you. I think that there are some, and you may also have some very significant stories about how people with disability really have some limitations in terms of their care. Part of that Barbara touched on, and that is that there is the view that there is a lot of complexity to disability. It is our belief that integrating disability into the curriculum will decrease some of these negative experiences because it will offer students an opportunity to see both the complexity of disability and the non-complexity of disability by giving students an opportunity to develop a deeper clinical understanding of diagnosis, of treatment, of disease management, of options that Barbara talked about related to disability. Now, much of what we learn in medical school is based on patterns. There are the patterns of typical development, the patterns of disease states for diagnosis, and to see if there has been any change in that. So when a patient with a disability is encountered by a student and a clinician, there's also the concern that there is significant complexity. There is a desire to possibly even avoid working with people with disability. Some people have the complexity of care, some people don't. Some people are complex without having a disability. But these are the things that I think are important for medical education. This is the opportunity to learn that complexities really should not overshadow typical disease states. So a person with a disability will present in the same way as a person without a disability, more than likely with their hypertension, with their diabetes for most of these states. The workup will be pretty typical. There might be some differences in consideration of management related to the disability, But this is also true for the general population, for people who work nights. We think of different ways and different strategies to engage people in appropriate management activities. I think this is particularly instructive. I'd like to give you a little bit of an example. We've actually put together 3 perspectives. You've actually heard from Barbara, but we do have a student and a patient and a physician perspective. This one is from a student, and this is a student who's now a 3rd-year medical student here at Upstate Medical University. And he completed an externship with our department in the summer between his 1st and 2nd year of medical school. And he called up with me to tell me about this interesting experience he had in his very first rotation in internal medicine. And, you know, after morning report, the students go and they pick up their new patients. And a colleague of his picked up a new patient that had suprapubic pain and urinary tract infection. And according to this student who picked up the patient, didn't really see anything in the documentation about anything else other than, yeah, there may have been some long-standing bowel or bladder problems. So the student goes into the room to begin to talk and examine the patient, and showing some very good observational skills, walks in, the patient's in bed, notices there's a wheelchair next to the bed. It's not a transport wheelchair, it's the patient's actual wheelchair. See, there's not a lot of movement going on except a lot of spasticity in the lower limbs, a lot of spasms going on, and not a lot of good movement of the hand. So the patient or the student recognizes that this is not just your typical patient, but wasn't certain how to approach the patient, introduced herself to the patient, said she'd be right back, goes out, looks over in the chart, still doesn't know what to do. And luckily, the medical student who had the summer experience was there. So many of the questions were, well, you know, should I ask about the disability? I mean, how do you ask about the disability? And should I just limit things to the urinary tract infection? And should I do a full exam? And what does that mean related to somebody with a disability? And why would there be suprapubic pain? I mean, isn't there supposed to be, with a complete injury, isn't there supposed to be no pain at all? And I really don't understand what it is I'm supposed to do. And gosh, I really don't want to go back into the room. You know, at this point, there's more students that are gathered around, and it's pretty clear most of the other students sort of were in the same basket. You know, I really wouldn't know what to do either. Well, luckily, our summer experience student was able to talk about a typical history and physical, discuss spinal cord injury, issues of incomplete injury, or at least the ability that folks with disability have with deep pain, that it's still maintained, and you know why it might be suprapubic and neurogenic bladder. And but the message was very clear that this was something that students did have some experience with. I know for a fact that there is a lecture about the pathology of spinal cord injury and how it manifests, and that there's problems with urinary tract infection and what tracts are involved, and what you see when there are differences with infection or whatever. And yet it wasn't enough for the student to be able to have that accessible and to be able to use any of that activity. And hopefully our experienced student was able to help folks move through that a little bit, and everybody learned with that process. But an important message is that disability is only one attribute, and that there are many attributes that make up our patients. But often it is that disability that gives people a bit of a desire or need to have a bit of a negative edge or a paternalistic response in dealing with disability, with people with disability. The disability is not always relevant, as I hope we've shown very clearly. This is another patient perspective. And it's important to recognize that patients with disability actually recognize when they've been viewed negatively or pejoratively. So this is a young man, 36 years old, who was born 3 months prematurely and did develop retinopathy of prematurity. So he now has no vision in his left eye, he has limited vision in his right eye, and he has nystagmus. So 10 years ago, we decided he should have a follow-up ophthalmologic exam, and that's very appropriate, and it's recommended that there be continual follow-up of this because of other secondary issues that may happen. So he kept his appointment with a new ophthalmologist that he had. So during the exam, the ophthalmologist said numerous times, "Stop moving your eyes." So eventually he said to her, well, I have no control over my eyes. I would control them if I could. And in hindsight, he did sense her frustration, but he was caught in this trap of, no, he wasn't being uncooperative, and gosh, he was really trying to do everything he could. This also led him to pretty much avoid not only eye care, which he's now gone back to, but also to avoid having routine physician care, which is truly unfortunate in this day and age. And our last perspective relates to the physician perspective. And the quote you see in the top there is from a physician who has had a chance to be a bit reflective. And those of us who have developed some of these relations, those of us who work with people with disabilities, who have developed relationships with other clinicians and practitioners who become a part of our team management process, hear this pretty often. We as physicians really need to recognize that there's no way we can know everything about everything. But what is important to know is, how do you respond to those kinds of things? How do you deal with those issues? First of all, it requires a physician who has some self-awareness. But from that, you learn to develop some compensatory strategies. As I mentioned, you develop partnerships, you have team management, you use some self-directed learning to learn more about these kinds of issues. You might even ask the patient about some things as well. I mean, there's always learning opportunities to be able to deal with patients in a very professional and respectful manner. The academic medical centers really offer an opportunity for students to see this kind of modeling, which, although we don't talk very much about this as an instructional method, can be a very, very powerful method. But one of the things we do need to talk to medical students about is dealing with issues of self-reflection and trying to learn a little bit, being much more self-aware. Which brings us to, so we believe that, at least those of us who are presenting this believe that there is a significant impact and there is an importance, but how can we actually do this? How can we actually integrate disability education into the curriculum? And I think that the AAMC and the LCME has really provided us with some real opportunities right now. We have some new terminologies, some new priorities, some new ways to approach medical education, some specific reporting requirements, all moving towards a more transformed educational system. So listed here are some of the areas where disability education really kind of dovetails, where you can actually get some integration. And the first one on the list is their purposefully, which is interprofessional collaborative skills or interprofessional education. This offers a real opportunity to deal with disability, because often people with disability do have to engage with more than a single physician, multiple physicians, multiple other professionals to be able to receive the appropriate care that is needed. This helps students become more comfortable in dealing with a variety of these issues. I think as you go down the list, it's very clear that population-based medicine has much to do with disability. We already talked about the epidemiology, patient safety issues, medical ethics, cultural competencies, disparities we've talked about, and communication skills. These are areas that are very much available to be able to help students learn a bit more about disability in more of an integrated way. And here we've put together a table of what we think are some active or interactive ways of learning, of instructional methods. And these are the ones that are supported by the LCME and the AAMC. And these are the kinds of things that are expected to be noted in the curriculum inventory report at each medical school. We'll talk a little bit later about some of the ways we've used some of these active styles in developing some tools that may be of some help. You'll notice we haven't actually added any of the more passive learning techniques, which are still common in medical education, and there certainly is a place for those. But we'll also talk maybe about some ways to make them a little more innovative and a little more engaging for students to learn more about disability. This screen depicts the curriculum inventory report from 2015 and 2016 that just looked at disability education. There were 77% of schools of the 134 that documented disability, that documented participation. 103 of them, or 77%, documented having disability education. But I did want to point out that the most common instructional method used is lecture, a relatively passive way of teaching about disability, an out-of-context, very segregated way of dealing with a disability. There are some others that were listed, and these are the top 4 that people identified that may be more interactive, that may offer some other opportunities. On the right, then, you see the box that talks about the physician competency reference set item that was covered with disability. From my perspective, 2 of them are a bit more passive than the other 3. So applying basic sciences and applying epidemiology makes a lot of sense. Talking about pathology, we've already talked about epidemiology. The more active ones, though, gathering information, doing some problem solving, engaging in decision making, are a bit more active. And at least from where I sit, it's hard to understand how something that is relatively passive way of providing information really can result in some of these more active activities. I'm very hopeful that those things have happened, and that may in fact be the case. But again, from my own personal observation where I sit, it doesn't seem to really make that kind of leap. And again, I go back to that particular student perception scenario that I presented, and we have many more of those. So it's not clear to me that having a more passive way of learning actually can be transformed into something that is much more accessible for our medical students to use. So again, we're promoting looking at disability education as being more active or interactive, and to actually possibly allow students to stretch a bit and often exceed their personal or maybe the educator's expectations, these umbrella expectations of objectives or competencies or EPAs. Again, it's the ability to feel comfortable, to approach a patient, to have some ability to deal with a little bit of that discomfort that you may not know exactly what's there, but you know you've got some tools, you can get in there, you can get some information, and you really have some idea, some generalized information that you know where to go for the next step. So we're suggesting that disability education really may have some disability-specific knowledge, skills, and techniques, that it is really more than awareness, and it is certainly more than changing attitudes. There is some new adult learning science that actually shows that you really can't change attitudes, which is typically the way we look at whether or not we've had any influence on education. Attitude change is really very, very short-lived, but students can learn to, if they even have that negative bias or that negative attitude toward a person with a disability, they can still perform very appropriate and very professional management skills in spite of that. And there is some good information that we have related to that. So we've talked about some of the innovative ways that are available, and now we'd like to give you some of our practical applications. Again, moving from not separating disability, not stigmatizing disability, but actually making disability education be a part of the fabric of the medical school curriculum. And there actually is some pushback or some blowback from doing some very separate education. There was a study that was reported on in 2014 by Dr. Andrew Simon that looked at students who participated in a curriculum on care for people with disability. And although there were some changes in attitudes, again, it was looking at attitudes, what really was very striking is that there were persistent negative attitudes that many of the students still had, that patients with disability were resentful of people without disability, or that they expected special treatment, which was a little bit of surprise to the people who had actually put together this curriculum. So again, I think this is a bit of a caution in trying to keep that issue of disability into a box. So what we're suggesting, again, is looking at these more broadly using the instructional methods that have been there. And I've noted a number of these. I'll talk about a couple of them. One is case-based learning. We've developed a scenario that looks at non-accidental trauma in a child with developmental disability that's set in the emergency department. Obviously, you need to have interprofessional education. It deals with pediatrics, it deals with emergency medicine, it deals with radiology. There are the competencies that are dealt with. There's also some support for the facilitators in dealing with this if this is going to require some facilitation. But it brings disability into the picture, but it also talks about all of these other issues. A problem-based learning tool. How do you discharge a patient from the hospital when there's been a problem? It could be that the family doesn't want to take the patient home. Is this a new disability that is a part of this? Is this a pre-existing condition, a pre-existing disability? Is there no family to assist? What are the options in the community? It's a lot of problem solving. And this is not an uncommon thing, particularly in the safety net hospitals, of which we are one here at Upstate. And again, looks at interprofessional education, patient safety, ethics, typically happening on internal medicine or one of the primary care services, and covering a broad range of competencies. So journal articles, we have a number of those that are there. This one that I mentioned is accessible offices and small group discussions. We've developed a model that looks at clinical competency, how it intersects with individual abilities and helps students recognize where things are and how to use disability in the area of complexity. I would like to point out that interprofessional education, again, makes it into here on a fairly frequent basis. I mean, this is probably one of those low-hanging fruits for partnership and looking at disability education. I'd like to highlight two other areas. One is the use of panels. Probably that's one of the second things that people think about in terms of lectures, or it might be even considered a lecture or maybe a large group discussion. Disability-focused panels, again, a little more segregating. Having a person with a disability participate in other topics, a bit more robust, allows people to see different perspectives. You know, again, interprofessional education, we had a very successful activity here at our institution where a group of panel members provided their experiences, their comments and opinions about the patient-physician dyad and giving and receiving care. And it was two clinicians and two consumers, and one of the consumers was a person with a disability. It was it was received very well, and it offered a very nice opportunity for students to hear very early on in their first year of medical education about the issues of people with disability. I'd also like to talk a bit about standardized patients. There's a lot of pushback about standardized patients because of concerns that this may be too challenging for students in these high-stakes examinations. You know, some schools use this for more of a formative evaluation rather than summative. But I would like to make the case that maybe it's important that we challenge our students a little bit more. Yes, it means that you have to have universal design and accessible facility. Yes, you have to have an organized way of recruiting and training people to be to have a standardized approach to these scenarios. And I mentioned the issue of grading. What I've identified here is a study that was done at the University of South Carolina on the family medicine rotation. It's a very nice study that talks about how this can be done, has been done, and has continued to be done. This has been longstanding at USC. I think there were two messages that came from this. One, you really can train people with intellectual disability and spinal cord injury to be standardized patients. Each of the standardized patients performed very well in being able to show the scenario or respond to the students. But the other more important thing that it showed is that students, in working with people with disability and these standardized patients, had difficulty eliciting histories, had difficulty completing physical exams, had trouble analyzing or ordering lab tests, and it was very clear that there were problems communicating with people with disability. And this really does show a gap in our medical education. There probably should be more emphasis on some of these things, not exclusively, but certainly as a part of the large presentation of information and education that we give to our students. And this last is a global and more encompassing need, and this probably is beyond the scope of what we're talking about today. But having a very open educational environment is clearly important, which includes faculty, staff, using appropriate and respectful language. This is our website, which will be live on October 30th of this year. It's going to be open access. We have developed a number of tools. We have a very dedicated staff of people here who are very interested in developing usable products that are accessible, and we continue to establish partnerships within our own institution. So our process is that we brainstorm with content experts from core departments and with disability experts. We choose a topic that's agreeable to all concerned. We begin to build a learning activity. We figure out the best educational method for presentation. We begin to identify what the broad expectations are, the priorities are to be covered. And then we, as we're building this, we're also looking for background and supporting information to be included. We have now, as you see, started to define a relationship with the Association of Academic Physiatrists, which is my national academic association, to actually bring in an element of evaluation and vetting, because this is actually the standard of best practice. To have other eyes take a look at these things, if we're going to offer it as open access, we really ought to have a more robust evaluation process. So that will soon be coming on board. And if you look here, we deal not only with active learning tools, but also continuing education and additional resources, including web-based resources, which I can tell you are not all as good as they might seem. So stay tuned for that. But in conclusion, I hope that we presented a sound argument and offered some solid options for tools to integrate disability into the existing curriculum. Disability education is more than awareness. Awareness may be a nice first step, but we really must move beyond that awareness, because it is important that we improve the quality of care for patients with disabilities, that we decrease the stigmatization of people with disability, we increase the opportunities for students to learn about complexities of medical care, and all in all, we benefit the healthcare system, our medical education, and individual patients. I have two thank you slides. One is to thank the people who have put together this presentation. We've had pictures of people with disability on each of the slides. You may or may not have recognized that they have a disability, and that was our purpose. So thank you to Rick Gadati and also to the Independent Living Center of the Hudson Valley from where Barbara is, for allowing us to use these images in a very important way. And I personally want to thank the Disability and Health Research team here at Upstate. Michael, Jeremy, and Katie have worked very hard. They have actually put together this PowerPoint. I am the voice behind the PowerPoint, but they have actually put this together, and they are dedicated and committed to continuing to provide this kind of infrastructure that we may continue with this. So we have about maybe 13 minutes left for questions. I'm not sure that there are any. At this point, Susan, do you want to lead us in any more conversation?
Q&A box. Could we invite Dr. Edward Callahan, the chair-elect of the GDI, to see if he has any questions or comments? Ed, are you there?
Yes, I am. Thank you very much, Susan. Thank you to everyone on the panel. I thought this was just a superb webinar, I think, introducing very critical areas. It's interesting that what you're doing is really working on getting people to recognize that disability is another intersecting aspect of people's identities and just as critical to knowing the whole person and valuing the whole person and providing the best possible care. So your message here about helps us understand that the disability is something that needs to be paid attention to, but is a normal part of every human's existence. Is just very beautiful. I love the emphasis that you have on the communications and relationships that are core here. It's as every part of diversity, those communications, those relationships are what's at core. I had not realized that people were denied care for disabilities or were treated roughly in the course of giving care, which is very upsetting, and it really emphasizes how important the work is that you're doing here. So thank you and congratulations to the team that put together all of this, from those people at Upstate and to everyone who's on the panel. Thank you on behalf of GDI for the powerful work that you're doing. Let me turn this over to people who have questions. Thank you.
Thanks, Ed.
You're welcome.
Appreciate that. Great. So looking at, we've had a few questions about being able to access the slides afterwards if you are interested in implementing some of these ideas or learning more about it. I believe that this recording is, this webinar is being recorded and will be available through the archive. Is there someone at AMC who can give more information about how to access the webinar afterwards?
Well, maybe I can jump in while we're waiting for someone to respond. There will be an evaluation form that will come out, and one of the things we're asking is if people are interested in more information or if people want to engage in this type of activity, and there will be a comment box that is there. So we are very interested in having more partners in this and in learning more from other people, because there are more than our brains who probably can develop some very important tools.
This is Diana from the AAMC. You're exactly right, Susan. We will be housing the recording of the webinar off of the GDI website, and that is aamc.org/members/GDI, and that should be up by next week. I see we've got a couple questions about that, so hopefully that answers other people's questions, but I do see that we've got a couple that are specific to the presentation, so I'll let Susan handle those ones.
Great, thanks. So one question is about whether there might be a list of objectives that could be used by medical schools to know what the goals are for the encounter or the learning element. Peggy, do you want? Have you developed a list of objectives for the encounters that you've incorporated?
We have not gone to that detail, although, Susan, I think that your group might be able to deal with that, but I think that can be very helpful. I mean, we've amassed a lot of information. We certainly can pull some of those things together, and again, if there are some specific issues at certain medical schools, we're happy to deal with that. I'm not sure any medical school has done an excellent job at integrating disability, so I think we're all in this together.
Yeah. Well, I can tell you one effort that I've been involved with comes out of a not-for-profit group called the Alliance for Disability in Healthcare Education, and they were interested in identifying the things that healthcare providers really needed to understand about disability in order for them to provide quality care. And our hope was that we would be able to come to a consensus on the core objectives or competencies that were needed for disability, and then try to add those competencies to healthcare standards. So we're in the process of trying to come to a consensus on what those competencies should be, and once we have that in the coming year, we'll be trying to disseminate those competencies or objectives and sharing them broadly. So we're working on it. There's another question asking us to speak in a little bit more detail about trying to integrate disability education into medical education in the context of incredible pushback from the school in terms of the amount of time and cost.
Well, I hope we try to make the point that it fits right in. I mean, not everything is about disability, but there are some things where disability can come into a conversation. I've looked at some of the things we have in our own curriculum, and I plan to make some individual contacts to see how disability might be a part of the large group discussion that they're having about stroke. There are some issues related to disability to stroke. I mean, the important things that people talk about, I'm sure, are diagnosis and preventing a second stroke and some of those issues that really are very important. But maybe there's a way to bring in just a little bit about disability. You have to do this with baby steps. Again, I think interprofessional education is probably the best place to have allies. Those are the folks that are trying to also find their place. Medical ethics is also another place that can be very effective. So I don't think there's an easy or a pat answer to this. It doesn't cost money. It's teaching the same principles. It's just having a little different perspective or using it as a second perspective, which is going to make the student a better clinician in the long run, whether or not we ask those questions on the examinations.
Yeah, and I would just add that another way to do this might be to recruit standardized patients with disabilities. So you could fold in the diversity of disability in your standard pool of patients that might be called up to portray any number of cases.
Well, again, I think that has been a big roadblock for us here, and we're building a new simulation center, and maybe things will change. But just having accessibility is somewhat of an issue. So having high-low exam tables. How many offices do you know that actually have high-low exam tables, which would be very effective for a variety of people who don't claim to have a disability as well. Even older people would be happy to not have to jump up on an exam table. So there are some things that you need to have in place before you can move down that pathway. And again, I think there seems to be some pushback in using simulated patients with disability just because of the obvious problems with or the lower grading that happens. But again, it's not insurmountable. There are ways to deal with that. And that's real world. That's already a system that's in place, and you could, I agree with you, Susan, you could actually bring that in, but you have to have some other things in place as well. Well, we're awful quiet here now. Are there any other questions?
There was one question asking for more information about, for you to give concrete examples of integrating disability education into clinical clerkships and how you can get buy-in from clerkship directors to do that.
Well, again, there's absolutely no easy answer. It requires a continuous conversation. people have often said that if you have a champion, you know, that's really what you need to be able to move things along. Well, having been a champion for quite some time, it's been a very slow uphill battle in trying to gain some entrance and get some traction for that. I don't think that there are some simple informations, but once our website is live, there will be some ways of people to get some of that already made type of tool that you can shop around, you can modify in ways that make more sense for you. You know, again, there's no easy way to do this. And I recognize that the curriculum is packed. It absolutely is. But there are small areas where you can move in. You know, pediatrics has been a nice entree as well for this. Neurology is a nice place to have an entree. Yes, they have much to do, but you know, a little bit of conversation, a little part of the discussion can go a very, very long way with students.
Great. One question about how to include guest speakers in a way that's not exploitative or harmful in any other way. Have you invited guest speakers for lectures?
Well, yes, and most of this is related to patients that I have come to know, and because of the long-term relationships, they are friends and sometimes their colleagues. There's also knowing the Independent Living Center in your community to be able to deal with those folks. There are a number of advocacy organizations where you can engage folks with disabilities. You can go to the PM&R department if you're, as I would say, lucky enough to have a department, and they can be very helpful in finding people for you. But I think that the question is actually very well put. It is important to recognize that how you invite someone is going to be very important, and how you set up the panel can really make or break the effectiveness of that kind of a learning strategy.
Thank you. There were a couple of questions about recruiting and using standardized patients with disabilities, and asking if we'd had experience doing that. Just recently, just this year, we were able to recruit a group of volunteers initially to work with medical students as standardized patients, and we had 29 adults. They were all adults, and about half of them had an intellectual disability, and we developed a scenario that we thought would be simple. We just set up a social history, so the students were instructed to go into the room and meet with the patient and take a brief social history. And they were told that there would be patients with disabilities, but not given a lot of information about the patient before entering the room. And it was a really rich experience. The patients, the volunteers, really enjoyed it. I think we had 100% of them wanted to come back and have another chance to meet with students. And we had a debrief time with all of the students afterwards, and they really enjoyed the opportunity to meet with people with disabilities, and said they learned a lot about the lived experience of people who have disabilities. So that was a success. The clerkship director really valued the students. We got good feedback from the students, and we were invited back, and the volunteers that we recruited were actually hired on as standardized patients, and so they can be paid now for their time. So that's one example.
There are some publications beside the one that I talked about that also talk about experiences with patients with disabilities as simulated or as standardized patients. Maybe we should have those online. As an aside, we are developing a number of tools that will deal with some of these issues and questions that people have brought up, not so much the simulated or the standardized patient, but I think that that's a good idea, and we can have some of those available on links as well.
That would be great. Thank you. I believe that we're out of time. So there are other questions. I apologize that we didn't get a chance to respond to all of them, but really want to thank the Group on Diversity and Inclusion for sponsoring this webinar, and to AAMC for prioritizing disability, and to all of the attendees for your attention and really great questions. Thank you.